Now 2022 edition of Fertility, Fact and Fiction. I am your host, Dr. Rahi Victory, a reproductive endocrinology and infertility specialist. If it's your first time joining us, welcome. We've been doing this for about 3 and a bit years now, I think. And we do a segment at the start where we review an article, talk about something new and upcoming, and then review all of the questions and data that we can in that instance, in that regard. And then we go over any questions that patients may have live. So if you have questions, ask and we will answer your questions live as best we can. Of course, nothing specific to anybody, but if you have a question, put it up there and we'll give you the general responses that we can. And when we can't, we set up a talk with you privately so that we can answer your questions one-on-one. So welcome to the show. I hope you guys had a wonderful holiday season. I hope everybody is safe and taking good care of themselves. As you are all undoubtedly aware, now more than ever, it's really critical that we take precautions and protect ourselves, because obviously COVID is running amok yet again. And so it's super important that you continue to maintain hand hygiene, maintain social distancing, avoid crowded places and crowded spots. So, and a special thanks to my kids who had to spend the holidays with their parents alone because they were avoiding getting COVID. So tonight's topic is a new and upcoming paper that is not yet published. It will be coming out in Reproductive Biomedicine Online. And it's about the use of letrozole in conjunction with other protocols to see if it can improve your success. Why is this important? Well, there are loads of studies looking at the use of letrozole for women with PCOS. It is now the first-line treatment. We use it for pretty much everybody. It works really well. We have no problems with it. It's been used for many, many years now with very good success rates, and there are no issues with that. And it really supplanted the use of Clomid, which used to be the first-line agent, but now letrozole has a higher success rate. Then they started using it for stimulation with ovarian stimulation protocols for IVF, mainly for poor responders. And then we started using it as well to suppress women after they've done their egg retrieval for patients that are at risk of hyperstimulation syndrome. Later, we moved into using it for frozen embryo transfers, where it has clearly demonstrated significant benefit in numerous studies, and it's now integral to our cycle management protocol. We use it for all of our patients and have very, very good results with that. So we're very happy because you get to reduce the amount of estrogen you need, and that's always a good thing. So we're getting very, very nice results with our frozen embryo transfer protocol that incorporates letrozole. No one knew for sure if it was beneficial for women that are poor responders, because there were many studies showing in some cases a benefit and in other cases not a benefit. And then also for women that are normal responders or even high responders. So along comes a new study where they have reevaluated this and looked at all the different groups in terms of poor responder, normal responder, and high responder, and took all of the different studies that they could find, amassed them into one, and tried to come up with a more cogent answer. So the title of the study is Co-Treatment with Letrozole During Ovarian Stimulation for IVF/ICSI, a Systematic Review and Meta-Analysis. And again, for those of you that are new to the show, all that means is they took all these different studies, they piled them into one, and then kind of crunched numbers and said, okay, when you take all these individual studies and you compile them, here's the answer that we get instead of just one study alone. So I will pull this up for you and start showing you some data. Oops. So most important thing to know is that the study basically started off like all good meta-analyses do, with an enormous number of studies included in the overall analysis. So typically when they're doing this kind of study, they'll include sort of 30, 40, 50 studies, and then they evaluate what that actually resulted in. So if you want to pop up what's on the screen share now, I'll try and blow it up a little bit so you guys can see it there. So as you can see, the important thing to realize here is they started out with 1,121 articles, which met their initial criteria. But then after they reduced it, they automatically ditched 1,046. They found an additional 5 from other records, and then they got rid of 1,046 out of this 1,126 because they didn't meet their entry criteria. And those are for a variety of different reasons. Maybe they weren't randomized, maybe they weren't high enough quality, maybe they didn't report on the appropriate outcomes. So then they were left with 80, then they took out 14 because they were just a review or an opinion paper. They took out 13 because they were other systematic reviews, which is a duplication of what these guys are doing. 13 had the wrong intervention. It wasn't letrozole, which I find quite funny, because you would think that if you're searching for letrozole and IVF, it would pull up an article on letrozole and IVF. And then 8 had the wrong study design, and 1 was on fertility preservation rather than actually treating people that had infertility. So they were left at the end with 31 studies. And when they analyzed them to see if they were low, medium, or high quality, they actually said most of these were between medium to high quality. There were a few that were in the low category as well. So pretty robust results overall. So interestingly, they then cite that when they looked at the live birth rate, when you read their abstract, does that still fit in the screen there? You should be able to see that. When they looked at the abstract, they actually say that there's a 7% increase in live birth. But the truth is, if you look at the numbers here, oh, it's going to wreak havoc on me. So if you look at the numbers here, and I'll try and blow this up for you. So right here in this, you need it even bigger. So right there where I've circled it in red, you can see that it goes from minus 0.03 up to positive 0.13. That's the live birth rate in poor responders. So what that signifies is that there is no significant benefit for these patients when they're poor responders for live birth rate. Now, in their abstract, they say that there's a 7% increase. So I'm a little bit puzzled with this study because it's saying in the abstract that there's a 7% increase. But when you actually look at the data, it's saying that it's non-significant. And you can see, again, in the little line with the diamond right next to it, that crosses that confidence interval line. And when it crosses the confidence interval line, that signifies that it's not actually going to be of any significant benefit. So they then said, okay, let's skip this, analysis. Let's go to the normal responders. There's no significant difference in the normal responders. And they didn't analyze live birth for the high responders because they didn't see a significant difference. Okay, so what happens when you go to the ongoing pregnancy rate? Well, ongoing pregnancy rate showed the same thing. There was a slight increase, but it was not statistically significant in the poor responders because it crossed that 0 line, went from negative to positive. It has to be on one side or the other to be a statistically significant difference. So they didn't see a difference there. They saw the exact same thing in the normal responders, no significant difference. And here they analyzed the high responders and again saw that there was no difference for the ongoing pregnancy rate. So live birth, they report as being higher, but we didn't actually see it. And the ongoing pregnancy rate, they actually don't see it as being higher either. What about when you look at the clinical pregnancy rate? So this is seeing a positive fetal heartbeat. So in this particular group, in the poor responders, in the normal responders, and in the high responders, again, they're not seeing a difference. So letrozole in these groups is not making a huge difference, although always in those poor responders, it's right on the borderline. It's just sitting on that confidence interval. It's going from minus 0.01. So kind of suggestive that there may be a benefit, but nothing very substantial that we would expect or that we would hope to see. So then they limited it to the really high quality studies. So when you limit it to the high quality studies, you can see here that if you look at the clinical pregnancy rate, and I'll kind of circle this whole area for you, there is an 8% increase in clinical pregnancy rate when analyzing the high quality studies. And when they went back and did this for live birth, they showed there that there was a higher chance as well, although they don't publish it in a nice, neat table like this. When you're analyzing just the high quality studies, they did show a significant increase, statistically significant increase in the live birth rate. So your clinical pregnancy rate goes up and your live birth rate seems to go up as well when you take just these high quality studies. You can see there that it goes from 0.01 to 0.15 with an average of 0.08. So that's an 8% increase in your chances of having a live birth if you've incorporated letrozole into your cycle. They did not see it for the normal responders. So there's no difference there, even when including the high quality studies. And they didn't see any significant difference in the high responders, although it actually, if anything, looked like it's a little bit of a lower chance. But again, it's not statistically significant in that group. Let's go to the miscarriage rate. So you can see here the miscarriage rate. And again, that's showing no statistically significant difference in any of the categories. You can see that diamond is almost sitting on that zero line. So you're not getting a benefit, you're not getting a disadvantage. Your miscarriage rate is the same. When they looked at the number of eggs retrieved, I won't go into detail, same thing. They did not see a significant difference, except for in the normal responders. So in the poor responders, they didn't see a big difference. But in the normal responders, they did see about 2 more eggs, which is interesting because in normal responders, we wouldn't normally think of using letrozole. But it does appear that if you're a normal responder and you're using letrozole, you may actually even get a few more eggs than you normally would. And then finally, the big one is, what about your drug consumption? So I'll mark this off for you guys because it's kind of hard to see without that. But when you look at the number of patients who used higher versus lower number of drugs, the group that used letrozole had way lower drug consumption in the poor responders, which I've circled in red there for you, and in the overall total as well. In the normal responders, they didn't see a big difference, but in the poor responders, you actually end up using lower doses of meds. This may have several benefits and may actually lead to the higher clinical pregnancy rate and live birth rate, because there are other studies that have shown that throwing loads and loads of meds at patients, especially when they're poor responders, could potentially have a detrimental impact. So this is a way to get an equivalent response without having to use as much drugs. You still get those nice eggs, you still get the good live birth rate and clinical pregnancy rate, but you can actually use a lower dose of medication. And when you're looking at this overall poor and normal responders, it still has a significant benefit. When you're looking at it in the normal responders alone, it's a trend, but it's not showing statistical significance. So we wouldn't use it in that group for this purpose necessarily. So essentially, when they looked at all of this data, they said that when you're looking at the duration, which was the next one that they checked, they said it was shorter as well. It goes along with the amount of drugs. So you get a little bit of a shorter stim. That means you're using less drugs. You're probably getting your eggs faster, which is good because we know if you go past 12 days of stimulation, it decreases your chances as well. And on top of that, you're getting a better live birth rate and a better clinical pregnancy rate. Is there a downside? No, because as we said, there's no decrease in the chances of, increase in the chances of miscarriage. There's no difference in ovarian hyperstimulation syndrome, although if anything, it was lower in the patients using letrozole. You can see here endometrial thickness, not significantly different in any of the groups. It is in the total. They showed a little bit of a thinner lining, but again, when you look at it in the individual breakdowns for normal responders and poor responders, it was not statistically significant. And the cancellation rate in all cycles was the same. You can see that here. So I'll blow that up for you as well. Again, no significant difference. So overall, where does this leave us? Well, the reality is it does look like letrozole can have some favorable effects in particular patient groups. In particular, in the poor responders, you're getting a better clinical pregnancy rate. You're getting a live birth rate that is higher when you're looking at the high quality studies. and you're using less drugs for a shorter period of time, which potentially has many benefits. So I think we're going to start incorporating this into all of our cycles moving forward. It's a very modest increase. You're only talking about 7 or 8%. But if I can improve your chances by 7 to 8% while decreasing your costs because you're using less drugs, and we get the same or better outcome, how can you possibly go wrong with that approach? I love doing these sorts of studies and evaluations. And we love doing the show because our own protocols get changed based on what we do for this show. So when we find great information like this, we always implement it into our protocols so that we can help patients. So this hasn't even come out yet. It may still go through other changes before they publish it, although they're saying this is a pre-proof. So basically, once we get the finalized version of this, verify that it is, what they were saying it is, we are going to implement this into our protocol and start using this for our patients who will hopefully benefit from it by saving costs, increasing their success rate, in particular in that poor responder group, and therefore get a better outcome than they otherwise would have before. Does this mean that the other things like estrogen priming and testosterone priming and DHEA can't be used? No, this is another tool you can use in addition to those. This is just another approach to things. You can still use an antagonist protocol. You can use a microdose fluor. There are different ways to do it, but it looks like incorporating the letrozole into your cycle can have some added benefits for you. I can tell you that we used it recently for one patient who felt that it was really supportive for her and it was going to help her. And we did much better when we incorporated the letrozole than we had when we tried it previous to that and had not used it. So I think this is something new and exciting. We're definitely going to start incorporating it into what we do, and hopefully we'll see the results that we want. So is it a fact or a fiction that letrozole will improve your cycle outcomes with patients that are poor responders? It is a fact. It looks like it actually can help you. So make sure if you enjoyed this video, you hit that like button down below. Make sure you punch the subscribe button and push notifications so that when we're putting out new content, you can learn along with us. We're going to start taking your questions live now, and my good friend Tarek is off screen, but ready to ask us questions in a whole new year of fertility fact or fiction. Fire away.
Should I wait until after my first trimester to get my booster shot?
Yeah, everybody's been asking that. So there's no proof, so we don't know for sure. But the reality is that the booster is no different than any of the other doses. And we do know that it's pretty safe to take them at any time. So if you're really worried, you can wait till you see the heartbeat, but you don't need to. There is no evidence whatsoever anywhere that the vaccines or the booster have any negative impact on your pregnancy. The only reason we occasionally tell people to hold off is because I don't want anyone to blame a miscarriage, which happens to 1 in 6 pregnancies, on the vaccine and then deter other people from getting the vaccine. So we'll sometimes tell you wait until 8 weeks or wait until 6 weeks, but it's not because of a risk to the pregnancy. It's about a risk of misinformation being spread because people will connect their miscarriage to the vaccine when in reality, it's much more likely to have nothing to do with the vaccine at all.
I used letrozole and the trigger shot with our last cycle at your clinic and successfully got pregnant on our own.
There you go.
I'm doing fab. Your staff was so caring and helpful. Thank you as well, Dr. Victory.
Oh, thank you. Well, that's great to hear. I'm super excited for you. We've had a lot of great stories recently, including one of our patients who is a religious watcher of the show, had very, very diminished ovarian reserve, basically borderline menopausal, and managed with just a natural cycle, IVF cycle, to conceive. So we're super excited for her. Individualization is so important, and letrozole can be an important part of doing that for some patients, obviously. So we're going to be incorporating that into things. But it's fantastic to hear that you had success, and we're super excited for you. So great news, and thank you for sharing.
Hey, Dr. Victory, how long should I wait for FET after COVID with minor symptoms?
At least a month or so to let your body go back down to normal. and get rid of any inflammation and immune reactivity. So I'd say about a month after that, you should be fine. Your body generally will respond back to normal, unless you're one of these long haulers. And for that, you'll know, because if you're still exhausted after a month, you would know. But usually that's not happening to the people with just minor symptoms. So hopefully you're okay.
Have you seen cycles after using letrozole be poor? I've seen some women try once with letrozole and the following cycle have poor outcomes versus using low dose stims like gonal.
I have not seen that, although we don't use a lot of letrozole, so maybe it's something we will encounter in the near future. I have not seen that myself, but it certainly doesn't have any kind of biological basis. There's no reason why letrozole would cause a benefit in one cycle and then a decrease in another. Now, keep in mind, there are waves of cohorts of eggs. And so if you are stimulating more of them to show up in the first batch, that might leave less for the next batch. So it's certainly possible that that's the impact you're seeing, but that should go away after a month. So if you did one, let's say in January, and you planned your next one in March, you should be okay, because it would be a brand new cohort of eggs. Excuse me.
What is the best way to prepare for a frozen embryo transfer?
So that's the eternal question. I think we'll probably be putting out a video very shortly on our protocol, so everybody knows. So let's go through the basics. So step one is you. So you need to get yourself into the best possible health you can. So exercise, meditation, acupuncture, yoga, all of these things have been shown to have a beneficial impact. If your weight is high, you must get your weight down. If your diet is bad, you must get on a healthy diet. The Mediterranean diet is supposed to be the best, so that can have quite a beneficial effect and should be something you strongly consider doing. So that's kind of the you part of things. From a supplement standpoint, vitamin D, your prenatal vitamin, melatonin, aspirin, if you want to call that a supplement or not. These are all important. We also use fish oils, and then probiotics and antibiotics first, followed by the probiotics, I should say, to optimize the microenvironment or the microbiome in which the embryo is being placed into. And then finally, your protocol. So contrary to popular belief, you want a relatively low dose of estrogen. So we are using letrozole. And then once we've used the letrozole, we are monitoring your lining very carefully, and we're monitoring your follicles as well. You want to make sure your lining gets to at least 8 to 9 millimeters. And once it reaches that level, you can start your progesterone. Progesterone then has to be both vaginal and progesterone in oil to optimize your success rates. Monitor your progesterone levels. You want them to be appropriate, not too high, not too low. And then you need an ultrasound-guided embryo transfer. There are studies that show that the afterload technique is best, which means one person is holding the outer catheter while the other person is loading the inner catheter separately. That supposedly gives you a better chance and a better success rate. Make sure you're putting it somewhere between 0.75 to 1.5 centimeters away from the fundus. Very variable results on that. A lot of studies say further back is better. Some say up closer is better. I know my last center I used to work with, the embryologist refused to put it too far back and always would put it way too high. And while our success rates were great, we've improved on those by moving it back a little bit because it was too far up in the fundus. So we're going, or at least aiming for somewhere between 0.5 and 0.75 on our program now. After that, you want to continue to monitor the progesterone levels. We do ask our patients to take it easy for 24 hours. That doesn't mean you need to go completely rock solid still and not move, but we don't want you running around doing a ton of stuff either. And then just think positive for the next 2 weeks. Do not go on Google. Do not go on Google. Do not go on Google. That's the number one most important thing. And then wait and see what your results are. Avoid extremes. No heat, no real cold, no significant dietary excesses. So you don't want to go on a sugar binge or a cholesterol binge, anything like that. And the most important thing, probably above and beyond all that, absolutely no smoking, no drinking, and no marijuana use. Those are huge. Keep your caffeine relatively low too, no more than 1 large cup of coffee per day. That's pretty much our protocol in a nutshell. There's some tweaking in there, and certainly we individualize for some patients, but the overall gist of it is there. That's what we're doing for you.
Thank you, Dr. Ricky, for the info. I switched clinics and got 6 embryos, 1 5-day 4AA,
Awesome.
and 5 6-day 4AA,
Okay.
and 4 AB.
Okay.
We'll be doing an extra day of progesterone for my 4th FET. Which embryo should I use?
The day 5 4AA.
I switched clinics, 6 embryos, 1 5-day 4AA.
Yeah, that's your best embryo. A day 5 4AA is an exceptionally good embryo. The day 6 5 is also very good, but the day 5 4AA is a spectacular quality embryo. We would call that a halo embryo, which is like, you know, the brass ring, the best one, the gold ring. You can't do better than that. That's an exceptional embryo. So I would use that one first.
Can you explain the benefits of Intralipids for someone with endometriosis, side effects, and what about Fragment?
Okay, so specifically for endometriosis, I'm not aware of anything that says that it's better, but that would be a cool one to look up. Let me look that up. The benefits of intralipids for any situation is that you are reducing inflammation and your immune reactivity. So if that is being extrapolated to endo, which makes sense because endo is all about inflammation, then that's not an unreasonable thing to consider. But whether or not there's data for that, I don't know. So let's check that out right now. We're going to learn together on the show. There is nothing direct that I can see, but there is a lot of stuff here on endometriosis with infertility. American Journal of Reproductive Immunology has one that's coming out. We'll have to look and see. I will read up on that one for you and find out if anybody has actually studied it yet, but I'm not aware of anything. Heparin is also a good anti-inflammatory, and because endometriosis causes inflammation, it can reduce it. But again, no one has specifically done a large-scale study of heparin use in endometriosis patients to see if it would benefit. Do we use it? Yes. And do we use intralipids? Yes. But I don't target specifically the patients that have endo. We're using it more for the patients where we are worried about an immune-mediated reproductive problem. Whether or not it's actually useful for those specific patients, I don't know. For endometriosis, I'm not aware of anything that has shown that it actually helps, but it may, and we can find out. Here's Intralipid, you know, and I just found it. Increased, here, I'm going to read to you from a study. Increased natural killer cell rates and cytotoxicity have been demonstrated in endometriosis-associated infertility, and in vitro and clinical studies raise the potential interest to use intravenous intralipid infusion to modulate the natural killer cell cytotoxicity in infertility. The data about the use of intralipids in endometriosis infertility report 3 women with increased uterine natural killer cells who received intralipid infusion on the day of embryo transfer in frozen embryo transfer cycles, second infusion after the positive test, and following infusions every 2 weeks. Wow, that's a lot, until the 12th week of pregnancy. And that resulted in live birth in 2 cases. So, like I said, the reason this is not on my radar is this is one study with 3 people in it, which is not a study. That's not even a case report. It's too low. So is it worth looking at? Absolutely. Is it absolutely going to benefit? We don't know yet, and there's certainly not enough data in this kind of category. Heparin, I don't even believe is on here, but it's certainly something that also is going to have some degree of inflammatory modulation. So I think your question is excellent. I just don't think there's a good answer yet, but certainly an interesting study and one that I will look into more. But this is a review article from 2021, so it's very up to date, and they are not demonstrating any significant findings yet.
Why do we want to use less estrogen for FET?
Because estrogen causes a lot of inflammation. And we know that in studies that look at fresh IVF cycles, where your estrogen level is much higher, the risks of preeclampsia, IUGR, probably stillbirth, pregnancy complications, and failure rates are much, much higher. In the cycles where there's frozen embryo transfers and the estrogen levels are much lower, you're actually doing much better. So the reason is postulated that it's all based on estrogen levels, and that it's those high levels of estrogen that are actually detrimental. And so by keeping the estrogen levels lower, you actually get a better outcome, not a worse outcome. I see women all the time who are taking tons and tons of estrogen, 2, 3, 6 tablets several times a day, to try and thicken their lining. I mean, if you have to thicken your lining, we do it too when we have no other choice. But if you can avoid it for the average patient, it should be avoided as much as possible. And there are other ways to improve your cycle outcomes and to thicken your lining without having to resort to estrogen. We just secured a contract with one of the very best producers of platelet-rich plasma. So we will start offering that service here this year. Hopefully within about a month or two, we'll have that up and running. We'll be able to provide patients with platelet-rich plasma infusions. That by itself has been shown to thicken your lining and to improve success rates, even in patients with unexplained infertility. So it could be a very easy, cost-effective way, even when it's an immune-mediated problem, to improve the quality of the lining of the uterus.
What is the best range of progesterone for FET?
Either 10 to 30 nanograms per mil or 40 to 100 nanomoles per liter. That's the ranges we use. Most people agree with that.
38 weeks pregnant, are there any pros to being induced before the due date, or is it better to go all the way to 40 weeks?
That's a great question. So there's a trial called the ARRIVE trial where they demonstrated that women that were induced at 39 weeks had lower risks of stillbirth, lower risks of preeclampsia, lower NICU admissions for their baby, and actually a lower rate of cesarean section. So we offer the induction to all of our patients at 39 weeks. And I was actually kind of pushing to induce all of our IVF patients at 39 weeks for the last 12 years, because I knew intuitively those are higher risk pregnancies and that there's a higher chance that the placenta will conk out on you earlier. And this data is basically supporting that information as well. So we definitely encourage all our patients now, certainly our IVF patients, I virtually insist on it, that they be induced at 39 weeks. It reduces your risks. It increases your chances of having a happy, healthy live birth at that time. And so it really makes no sense not to do that. Natural is not always better, guys. People always have this idea that natural is better. A lot of women turn to some very archaic techniques and treatments because they think that we are too interventional. When people used to deliver completely natural, there was no intervention, antibiotics, vitamin K, all of this different stuff that we do, oxytocin and so on. The rate of complications, including fetal loss during pregnancy or labor, was sky high. It was insanely high. So we are not hurting people by doing what we are doing. We are benefiting the most number of people possible. Are some people getting treatment they don't need? Yes. But overall, is it providing a safer, happier, healthier outcome for everyone? Absolutely it is. There's no question.
Hi, Dr. V. Does taking biotin and collagen as supplements good or bad if I'm planning to do IVF?
There isn't a lot of data on that, but there's nothing bad about biotin or collagen. So it's not going to harm you or your attempt to get pregnant in any way. There's no data showing it's detrimental. I'm not aware of anything significant showing it's beneficial, but I don't know of anything showing that it's detrimental.
Hi, Doc. I'm 25 years old. My diagnosis are inflammation in the blood, and my doc suggests low dose. I guess it's aspirin, but they wrote aspirin. What can I do to improve my IVF chances?
Well, that's probably, if they think you have an immune problem, low dose aspirin is not enough. There's all sorts of things. So there's intralipids, there's subcutaneous IG, there's IVIG if you're a billionaire. There is steroids, there is tacrolimus or sirolimus, there's plaquenil. There's a whole host of different things that can be done. Intralipids. So yeah, there's all sorts of things we can use to improve your chances. Aspirin alone is insufficient if you have an actual immune-mediated physiological problem. You need more than that.
Hey, Dr. V, can you use your protocol with a modified natural cycle with Lebanox and steroids?
Yeah, absolutely you can. Sure. Modified natural cycle, you can, we use a modified natural cycle. So we're using letrozole and then very little estrogen. We do use progesterone. And yeah, we use steroids and Lebanox all the time. So that's very easy to do. It's common.
Hey, Dr. V, for FET, I had 2 LITs plus 3 intralipids. The protocol is 17 days of birth control, 2 weeks of Lupron, and approximately 2 weeks of estrus plus aspirin, vitamin D, and start progesterone 5 to 6 days before the transfer. Maybe sure, I don't know. What do you think? I'm in day 11. Can I start letrozole and probiotics? Thanks in advance.
Day 11? I'm on day 11.
Protocol is 17 days of birth control. That's part of the other hidden part. Hold on.
Yeah.
I'm in day 11. Yeah.
Yeah, I wouldn't start letrozole on day 11. You need it from day 3 to 7. It's too late now to start your letrozole. We don't use birth control in the patients that have had immune-mediated problems usually, because again, you're giving estrogen, and we don't really want to give patients estrogen when there's an immune-mediated problem. We want to keep that to an absolute minimum. That's not to say it's a bad thing. It's not what we do. I do like the idea of using letrozole for you, but you would have to start from scratch. So I don't know if that's worth it for you or not. Otherwise, there's nothing major wrong with what you're doing. We just don't use the estrogen. We use the letrozole instead. I would say you're getting a fairly typical approach to things. I'm not the typical guy, though. So we try and use a more scientific basis for things based on all the stuff we do here on the show and reading and research and so on. So our protocol is quite different, but there's nothing wrong with what you're doing. I would just argue that you can do better, but you will do fine with what you're doing. There's just ways to improve it.
Hi, Doc. My diagnosis are high inflammation in the body, and my doctor suggests low-dose aspirin. What can I do to improve my IVF chances?
I think that was the same person that asked before, right? Yeah.
Yeah.
So we answered that question. So, yep.
I'm from India.
Oh, hey. Hello from India.
India.
What time is it in India? It's gotta be
late.
It's gotta be like
maybe they're
5 in
starting.
the morning.
They must be starting the day.
Okay.
44 years old.
44. Okay.
My AMH level is very low.
Okay.
Any medicine for fertility?
So you can go basic, like just take the pills, or you could try the injections if you want to try the injections. So letrozole or Clomid. You could try the shots, which are the FSH, Gonal-F, Menopur, Puregon, Ravel. There's a million of them. So any of those will work. DHEA can help. Human growth hormone may help, although they're less convinced about that one. Testosterone priming, estrogen priming can also help. So any of these are reasonable. Like we just showed you on the program, letrozole may be beneficial if you're a poor responder. The major issue you're running into at 44 is that even if we can help you produce eggs, we're helping you produce eggs that are predominantly genetically not normal. So even if we do get you pregnant, you're at a higher risk of miscarriage because by 80 to 90% of the embryos will be genetically not normal. In fact, even higher than that. It's probably over 90% of the embryos will be genetically not normal. So that's definitely concerning, but there's no reason you can't try. Like I said, we have one patient that was almost menopausal at a young age, and we got her pregnant. So it's doable, but it's difficult.
After 2 failed transfers, would you recommend trying a different RE who uses a different protocol?
So there's a really interesting study by Richard Scott's team, which demonstrated that if you did absolutely nothing, no intralipids, no immune protocol, no anything whatsoever, and transferred 3 genetically normal embryos, you would end up with a 95.2% chance of a live birth. So you don't have to do anything after just 2. Having said that, in our program, I don't like failure. So if we haven't succeeded within 2 tries, I want to start exploring why we're not successful. Do you need to go to a different RE? I mean, that depends on how willing your RE is to help you and to consider alternatives. If your RE is adamant that it has to be just the same thing over and over and over again, we always tell people that, the definition of madness or insanity is to do the same thing over and over again and then expect a different outcome. So, that's just not a good plan. But if your RE is willing to think outside the box and start doing some additional testing and explore the possible causes of why you're struggling, well, then I wouldn't switch RE. So if they are willing to work with you to explore for answers, you don't need to switch doctors. If they are not, then yeah, I definitely recommend switching doctors, because your doctor, no matter what field of medicine it is, needs to be able to communicate with you. You have to develop trust with that doctor. You have to feel like they have your best interests at heart. If the doctor is only willing to do the same thing over and over again, especially for something so important where we're dealing with human life, we're dealing with your emotions, we're dealing with your psychology, we're dealing with your partner, their feelings, their emotions. I mean, it's a lot to bear. And it's not something where you just say, let's just keep doing the same thing over and over again. Trust me, it's something that merits a discussion. It merits involvement. It merits a dialogue. And I mean that in the Latin Greek term of dialogue, which is, bidirectional communication. So it's got to come from you, and it's got to be listened to by you as well from somebody else. So yeah, I think that has to go through. If that's not happening, you're not being listened to, then switch. I know I put up a recent Instagram post where we basically said one of the number 1 complaints of fertility patients is they are not being listened to. And so you need to listen to people to understand them. And then only after you've heard them can you actually think about what the right thing to do is. I get requests every show and pretty much every day from people saying, this is what I've got. What do I do? You know what? I can't tell you what to do from an Instagram post, guys. I need an hour-long talk with you to know every single thing about your history so that I can figure out what the right thing to do is. We have another great success story from a patient that watches us on IG and learned about us and communicated with me. And it was literally as simple as getting her partner to cut down his smoking and quit. And they got pregnant on their own and didn't need anything. Like literally all they needed to do was, cut down smoking. And she had a super complicated history with, previous complications from cancer. So sometimes it's very simple, but I need to listen to your whole story, understand you, and then give you appropriate feedback to help you.
Hey, Dr. V, is high AMH good? But in this continuation, if an egg donor, 25 years old, had a high AMH, is that a good thing? She had a retrieval in the summer and had 26 embryos that made it to day 5.
Wow.
All PGT tested. What are the odds of that happening again?
So too high an AMH level has been associated with decreased egg quality, but that doesn't sound like it's too high. I mean, it depends on how many eggs she produced. But the higher the AMH, the more eggs you're going to produce. We typically want women with high AMH if they're an egg donor, because we want to produce a lot of eggs for our clients. We do a lot with the LGBTQ community, and if there are 2 men involved, we need a lot of eggs because we have 2 sperm sources to accommodate. So we're very comfortable dealing with high numbers of eggs. You don't want to overdo it because you will impact the egg quality. But if you can get like 20 to 25 eggs, it's kind of the perfect number, and that's what we target. Do we get 50 sometimes? Yes, but we're really aiming for that 25 number sweet spot.
In the FET, we start estrogen on day 1. Then progesterone from day 15. I want to ask, does the body not make its own progesterone during the FET cycle? What if body starts making own progesterone from day 14?
Okay, so that's a great question, and thank you for asking that. The reality is that protocol is not a good protocol because it's too formulaic. You can't just say I'm starting estrogen on day 1 and I'm starting progesterone on day 15. You need monitoring. You need to know if you're growing an egg. Now, if you're starting enough estrogen, you frequently won't grow and release an egg. But if you do, you will start producing progesterone. And if you start producing progesterone, you're completely screwed as far as your cycle timing is concerned. So if you started, like, let's say you released your egg on day 12, and then you start your progesterone on day, I don't know, let's say you started on day 15, and then you continue it for 5 or 6 more days, you're actually being exposed to like 7 or 8 days of progesterone. You're on birth control now. You're not on fertility assistance. So it's critical to be monitored. No one will ever succeed with a program where it's that formulaic, where you say, hey, on day 1, I start this, and on day 15, we start that. It has to involve monitoring. Every patient is individual. Everybody is different. Everyone's physiology is different. If you do cookie cutter medicine, you're never going to succeed. That's part of the reason our success rates are so high, is we do whatever is appropriate for each patient. We don't do what's just best for making money or for ease. We do what is best for making sure that we succeed with every single embryo. I literally don't want to fail. Like, it's very frustrating for me personally if even one embryo gets wasted. So we want to make sure each and every embryo transfer gets the very, very best chance possible. So you can't do that cookie cutter kind of approach.
Hey, Dr. Victory. My wife is currently 11 weeks, and despite the ultrasound going well, she had virtually no symptoms. Is this something to be concerned about?
No. Great question. So we get asked this every day. And the reality is everybody's pregnancy is different. Some people are vomiting nonstop from day 1, and other people never even realize they're pregnant. So, everybody is different. Everyone's physiology is different. No 2 pregnancies are the same. Even in the same woman, you can have one pregnancy where she sails through it, and then in the next pregnancy, she has a horrible, difficult time. So you don't need to worry about symptomatology. If you have a live baby and you've seen a positive fetal heartbeat, your risk of miscarriage is very, very low, typically less than 2%. At that stage, you don't need to worry anymore. You're probably in smooth sailing territory, unless there's some complicated problem in your history, but otherwise you should be in good shape.
Thoughts on using letrozole 2 to 3 times a month versus Lupron Depot before an FET for possible adenomyosis in a 42-year-old patient?
So if you have adenomyosis, the appropriate protocol is 3 months of Lupron and letrozole daily for the whole 3 months prior to doing an embryo transfer. Letrozole a couple of times per week for a few weeks is not a good idea. And it's certainly not a replacement for Lupron. Your adenomyosis feeds off of estrogen, just like endometriosis does. And so you need to completely shut down the estrogen. So in order to do that, you need Lupron and you need letrozole continuously to get that benefit. Otherwise, you're not going to see the same result. I would definitely not recommend hit and miss letrozole. I've never even heard of that before, nor would I ever endorse it. That doesn't make biological sense at all.
Just had a surgery for fallopian tube removal, and they found severe endometriosis.
I'm sorry.
The surgeon did remove a lot. Uterus looked okay. Any advice for an FET protocol? And how long should I let the body heal before the FET?
Go immediately on 3 months of Lupron and letrozole. Take NAC, inositol, curcumin, coenzyme Q10. How severe it is important. You may want a bit of an immune protocol, but those are the basic things that help you. When it gets around time to do the embryo transfer, take little to no estrogen at all. That's another space where letrozole is the way to go. So extend your letrozole a few more days, stop it, and just let your body naturally grow your lining. That's definitely your best approach to things. But you need suppression. The surgery enough will often not be sufficient for success. And try not to go more than 6 months before you do your embryo transfer, because your endo can come back by that time.
36 weeks, thanks to your advice.
Oh.
Found out baby is breached today. Thoughts on ECV or other suggestions?
So ECV is an external cephalic version. Years ago, I used to get one of my colleagues, the wonderful Dr. Mundell, to do them for me. And one day it took way too long for him because he was busy doing something else. So I just went ahead and did it myself. And I have to say, I'm really good at doing them now. So I'm very comfortable doing them. You have to do it right, which is to say the patient must get an epidural. She has to be really comfortable. You can often give them nitrous oxide. You want to relax the uterus as much as possible. And then you just need to know which way to rotate the baby. And you need to be very prepared to do an emergency C-section because not all babies like being turned and some of them don't react well and their heart rate drops and you have to get them out quick. But if you have enough room in there, your baby is not huge, you don't have any kind of uterine abnormality, it's definitely worth a discussion with your doctor to see what's right for you. And I have no hesitation trying for the majority of my patients, especially if they've had more than one baby. That's a no-brainer. Even if they haven't, it's reasonable to try. Keep in mind that whatever has led your baby to be breech in the first place often is a narrow pelvis. And if you have a narrow pelvis, the baby may not fit through even after we've turned it. So there are times, to my great, great dismay, where I put the poor patient through the trouble of spinning the baby around. We're successful, and then we put them into labor and they need a C-section anyways. Still worth a try though, because a lot of times we are successful, and so it's worth trying.
New information.
Oh yeah, Tarek didn't know that one. We should call it Stump Tarek. Yeah, Stump Tarek question.
What are the best ways to induce a pregnancy?
Oh, they mean like to do an induction. I was like, sex is the best way to induce a pregnancy. Okay, so there's 3 different ways you can do it. So one is trying mechanical, which is sweeping your cervix. So we put our finger through your cervix, you get between the bag, which is over here, and the uterus, and you go like this in order to sweep and create a space between the amniotic sac and the uterus. That releases prostaglandins. The prostaglandins soften and ripen your cervix and helps you get into labor. It's not a bulletproof or foolproof technique, but it does help and it's reasonable to try. It's uncomfortable. It can cause some minor bleeding. It's pretty much risk-free otherwise. Option number 2 is you put a balloon through the cervix, so it goes right through. The balloon has to blow up inside the uterus. If it's blowing up inside your cervix, it's excruciatingly uncomfortable, and you need to tell your doctor to stop and advance it further. It basically does the same thing the sweep does. It separates the membrane from the uterus. That releases prostaglandins. That helps soften and open your cervix. The third choice is to actually just take prostaglandins. Excuse me. So that can be done orally, vaginally, or rectally. Most of the time we just use it vaginal because that has very good absorption and very few side effects. You give it that way and you wait, and then we bring them back and do it again. And it actually has the highest success rate of putting you into labor. Those are the techniques we use.
Hey, Dr. V, my husband, Hey, Dr. Victory. After the new COVID announcement and non-essential surgeries paused for 2 weeks or more, has the wait time changed for your endo surgeries with you?
Yeah, it's not looking good, folks. So with surgeries on shutdown again, we're at the mercy of the hospital. I have no idea what's happening. I was just notified the other day that my entire surgery day tomorrow is canceled. So we don't know what is going on and we don't know when it's coming back to normal. I have no idea. We are going to start doing some surgeries in our office, hopefully soon. We have to apply to the college. They got to give us permission. That should clear some of the stuff that we're doing, but I'll let you know as soon as we know anything different. At the moment, I've lost complete faith in anything about the hospital system because it's total chaos with COVID. We just don't know when we can do things or what's going to happen with the next day. We have anesthetists off. We have nurses that are off. We have doctors that are off, assistants that are off. Everybody's off because of COVID. So there's no easy way to get around this, guys, unfortunately. And I'm so sorry but it is wildly out of my control. Wildly.
Hey, Dr. V. My husband has low morphology and we're doing modified IUI. I'm starting overdraw trigger shots.
Okay.
But I've also heard that he can take Clomid to help his count and motility and morphology. Have you heard of men trying Clomid?
Yeah, so Clomid is useful if the guy has low FSH-LH and a low sperm count. It has nothing to do with motility and definitely has nothing to do with morphology. So morphology is usually related to low vitamin intake, bad habits, smoking, drinking, drug use, obesity, diabetes, lots of inflammation, bad diet, that kind of thing. Motility, same. All of those things can impact it, in particular smoking, drug use, marijuana, that kind of thing. But for your count, you can use Clomid to increase your count, but it generally only works well in guys that have low FSH-LH because the brain is not sending the signal to make the sperm to begin with. We have used it in guys that aren't suffering from that. It doesn't work quite as well, but it does work sometimes. So it's worth considering, but it's definitely not indicated for that purpose.
If I did a funded IVF, is it possible to transfer my embryos to another clinic in Canada?
Yes, but you will lose your funding. So when you take them to another clinic, for example, we have lots of people that want to come to us with their funded embryos. So they're pulling out of the funding program. They're shipping their embryos to us. You don't have to pay us, unfortunately, for the embryo transfers. But as long as you're willing to do that, there's no harm. You can get out of funding. Taurus got a very funny look on his face.
I've heard you speak on the benefits of unprotected sex to help uterine lining and subsequently a positive transfer.
Yeah.
But how do I approach that concept when I'm trying to clear up a bacterial infection in my uterus, urea something?
That's a good question. So you need to make sure you and your partner are clear first. Once you're clear, you can go ahead and do that. So that's easy. It's just chronological. So get you treated, get him treated, make sure you're both clear. And then once you're clear, you go ahead and you prep for your embryo transfer, and then you can have as much sex as you want. And yes, ejaculate does prep the uterine lining in order to get it ready for an embryo transfer. So that's not an unreasonable thing to consider.
Hello, Dr. V.
Hello, whoever.
All the way from California.
Callie. Hello, Callie.
Nice and warm. Do you guys manage IVF cycle for patients who are in the U.S.?
Yes.
For example, can I be your patient here in the U.S. but cycling and being managed by your clinic?
Yep, absolutely we do. We have lots of patients from the U.S. Probably about 10 or 15% of our patients are now from the U.S. We just had one couple that did the best they'd ever done with us. They were over the moon ecstatic with their experience. I love that couple. They know who they are. Hello, New Jersey. And we had another couple from the Virgin Islands. We've had several from California. We have donors coming. We've got lots from Michigan because they're right next to us. So yeah, absolutely. If you're coming from Cali, we would be more than happy to take care of you. It is infinitely cheaper, even with the travel built into it. And quite frankly, we do a better job often than many of the American places do. So definitely reach out to us. We're more than happy to help you. Just contact info@drvictory.com. Ask them for a consult. Our consults are ridiculously inexpensive. We'll be happy to spend an hour with you. I go through Zoom, do everything you need to get it set up. Sometimes you don't even need to come to us. We can give you enough advice to get it done where you are. And if you do want to come to us, by all means, we're happy to help you.
I worried about all my embryos being in the 3 range, all 3AA, 3BB, and 3BA.
Yeah.
And 1 4BA.
Oh.
All 5-day, 5 or 6, all PGT normal, but still worried it may not work. We male factor and PCO, and I'm 36.
A grade 3 embryo is not as good as a grade 4, 5, 6, but it's still very reasonable, and there's no harm in that. It probably means, and you'd have to find out, that they froze them earlier than they were supposed to. Keep in mind, if you leave a 3AA embryo till day 6, or even later on day 5, it's going to become a 4, 5, 6. So those are great embryos. I would not be worried about that. They're probably perfectly fine, and we would use that. I'd be worried if they were less than 3, but a 3 is still okay, and that meets our quality metrics for accepting embryos from another clinic. So if they're a 2, we traditionally won't take them, but if they're a 3, 4, 5, 6, we will. And AA quality is great. AB quality, BA quality, those are all good embryos.
So special referee, 9 o'clock, and kabillion questions.
A kabillion? A kabillion?
That's the number of the day.
Everybody's been waiting for 2 weeks. Absence makes the heart grow
I'm telling
more
you.
questionable. I don't know. What do you want to do?
Whatever you want, I'm here.
Well, we'll give you guys another 5 minutes, and then we'll answer some more questions. Yeah, and then I guess take screenshots, and I'll try and answer them next time, or whatever. We can answer them next week.
Can there be embryo genetic issues if miscarriage happens after seeing cardiac activity of 147 BPM?
Yes, absolutely there can be. So cardiac activity does not mean that the embryo is genetically normal. It is more rare to see a miscarriage after a cardiac activity is seen. However, it does not rule out a genetic problem. You can still very much have a genetic problem. And if anything, arguably, it's still probably up there as number 1 on the list of causes.
How long should I wait to transfer after COVID-19 after being vaccinated? I'm getting monoclonal antibodies tomorrow because of my asthma. Would March be enough time?
Wow. Should be. March should be plenty of time. You should be down by then. Yeah.
Dr. V, can D&C cause periods to go lighter? My cycle is regular, but I've got more lighter and shorter 3 days after D&C, 3rd day of spotting.
Yeah, make sure you're doing an SIS to rule out that there's any scarring in the uterus after the D&C. And if they were aggressive, they could have scraped or scarred the lining a little bit. So you need a saline infusion sonohystogram. You can watch our fantastic video, which today hit 33,000 views. I was quite proud of that.
Cool.
So yeah, watch our video on saline infusion sonohystograms on our YouTube channel. Also watch Embryo Math. So those are both great.
What about the one you just did?
Oh, watch our orgasm video. I looked a little too excited doing that one. So we have a great video on using Viagra for women. So check out our new video on Viagra for women because it works really well for orgasm dysfunction. And we're going to have another video coming out all about the female orgasm very, very soon. So we're hoping that one will hit 1 million views.
Mm-hmm.
Okay, next.
My wife has been tracking a fairly large SCH, started at 5.7 centimeters. Thanks to bed rest, is now down to 1.7 centimeters.
Oh, great.
When can she be active again? Walking, ellipticaling? What type of activity is okay during preg?
Light activity even now would probably be okay. I mean, certainly walking, not like power walking or exercise walking, but wherever you need to go. Elliptical, I probably wouldn't be doing it all anymore because the SCH can't come back. And otherwise, light activity is fine. Nothing heavy, nothing crazy. I'd still avoid sex. Sorry.
What constitutes a natural cycle?
Yeah, there's great debate about that, but traditionally a natural cycle is no estrogen, maybe some progesterone. You just wait for the patient to trigger on their own. You wait for their LH surge, and then on LH plus 7 or LH plus 6, depending on who you read, you do your embryo transfer.
Is fresh or frozen more successful when doing a donor egg IVF?
So in a good program, it's probably equivalent. We try for fresh when we can, less for success and more for patient frustration reasons, because we want to minimize your frustration. But in our experience, it actually doesn't make any difference, because the problem with fresh IVF success rates being lower is because in an autologous situation where it's your egg and the embryo is going back into you, your estrogen levels are very high, which negatively impacts your success rate. But when we're taking donor egg, it doesn't matter how high the egg donor's estrogen levels were. We're taking the egg out of that environment and putting it into you, where hopefully we have not jacked up your estrogen levels. So we aim for fresh, but it's no big deal if you're doing frozen, as long as you have a great program with amazing protocols and amazing success rates, which we do.
Hey, Dr. V, 3 letrozole cycles have failed.
Oh,
I have PCOS. I know you said to wait till 6 cycles, but can I do something additional with letrozole every month, but no success?
Yeah.
Losing hope.
So make sure you're doing your NAC, your inositol, and your coenzyme Q10. Make sure you're exercising. If weight's an issue, you have to work on the weight. That is imperative. Any PCOS question, we always talk about the 3 prongs, right? So prong number 1 is you must do healthy living stuff. So healthy living is exercise every day and an appropriate balanced diet, which is no more than 1,500 calories per day and split across 6 meals to get your insulin levels down. Number 2, or prong number 2, is making sure that you are taking appropriate medications. So letrozole, and then if you need metformin. Plus, there's some data that dexamethasone can be helpful for women with PCOS. And then number 3 is the natural supplements. So those are inositol, coenzyme Q10, and NAC, NAC, or N-acetylcysteine. So all 3 of those are important to improving your success rate. If you try just one of those or 2 of those, it doesn't work very well. You have to do all 3 to achieve success. Still a bajillion more questions.
Whatever the number I told you, that's the number you got.
Guys, we cannot go on forever. Do you want to do another?
I'm trying to find a terminal question. They all seem like they need effort, but they're not terminal. I feel the pressure. Okay. This guy says his question got skipped. Let's give it to him.
Okay.
How to give a sample for sperm DNA fragmentation?
That's easy. Just give us a sample. Is there more to that question?
I'm sure he's going to feel ripped off if I don't find it.
So if you need to give us a sample for sperm DNA fragmentation.
Timed intercourse cycle with letrozole. Okay, here it is. Hey, Dr. V, 3 letrozole cycles have failed.
Yeah.
Have PCOS. I know you had said to wait 6 cycles.
We just did that one.
Oh, no. This is live. I got Then he's good.
Tarek had a mini stroke. Sorry, everybody.
All right. Last question.
Wait. Let's do the DNA frag, guys.
Okay.
So if you have a DNA fragmentation request, all you have to do is give us a sample and tell us you want it marked for DNA fragmentation. So we'll take it, we'll process it. We do the DNA frag. You have the results pretty quickly. So it's very, very easy to do. Don't hesitate. Just contact the front desk and we can make arrangements for that.
Hi. 3rd euploid transfer after 2 fails.
Oh.
At our 6-week ultrasound, everything was there physically, but no heartbeat. Next week, there was one. Wife is now 11 weeks and doing well.
Okay.
He wants you to do the crystal ball. Chances of a live birth.
Oh, at this stage, less than 2% chance of a miscarriage, probably even less than 1%. So 99% chance you're going to have a live birth. Yeah.
Congrats.
Okay, folks, that is a wrap for us on Fertility Fact or Fiction. Let us know what you thought of the show. Give us some thumbs up. We want to know what you think. Special thanks to Tarek from Ibrahim Strategies Group for his amazing year of service to us last year and for many more years to come. And we will be live again with another show. I'm not sure when. I think next Monday night. So we will see you then. I'm in Toronto on Sunday doing surgery for tubal reversals. So let us know if you have any fertility questions. If you are from overseas, the US, South America, North America, Europe, India, Australia, Japan, it doesn't matter. We take patients from all over the world every single day. It's a huge part of our business and a huge part of what we like to do. And don't hesitate. We are not about pushing people into therapy. Like I said, I'm actually most happy when I avoid doing IVF for people. If you can just talk to me and I can help you get pregnant naturally, that's a huge win for me because I feel like I've done the right thing. So reach out to us, VRC. We're here for you.